And now I would like to welcome our third speaker, and Sophia Skou Thomsen, ophthalmology and postdoctoral researcher at Riks Hospital in Copenhagen, Denmark, who will discuss surgical simulation versus surgical real training. Thank you so much, Anne.
Thank you very much for the invitation. My name is Sophia Skou Thomsen, and I'm an ophthalmologist at Glostrup Hospital in Copenhagen, Denmark. I'm also a senior researcher and program director in ophthalmology at CAMES, which is Copenhagen Academy for Medical Education and Simulation. My talk today is about surgical simulation versus surgical real training. And my background for talking about this topic is that I have completed a PhD in this field, specifically on the use of virtual reality simulation in the assessment and training of microsurgical skills in ophthalmology. So this is an area that has been dominated by personal opinions, and this is our attempt to support this area with evidence-based knowledge. There's been a huge increase in the number of relevant training models in ophthalmology during the last decade. For many years, animal models have been used as a primary training model, and there are several available inanimate eye models now, as shown here. And then we have the virtual reality simulators, such as the Help Me See simulator for M6 surgery and the IC simulator for phaco and vitreoretinal surgery. So our main question is whether training on simulation models work or not. I will focus on cataract surgery for several reasons. It's one of the most commonly performed surgeries. The learning curves are long, and it is the area on which most research studies have been conducted. Here it's relevant to look at the highest evidence levels, which is transfer of skills to the clinical setting, which is the operating room, and improve patient outcomes. So we now know that virtual reality training has a significant effect. We know that novice surgeons perform better in the operating room and that complication rates diminishes. There's a huge UK study showing a 38% reduction in the posterior capsule rupture rate after having implemented virtual reality simulation training as part of the training program. There's a US study showing a 68% reduction in the number of errant capsulorhexis. And this graph is from one of our own studies investigating the transfer of skills to the operating room. And it's depicting the performance score on the y-axis, where experts have rated surgical performance on videos using a validated checklist, which is the OSAX. And then we have experience on the x-axis, which where we have the number of phaco surgeries the study participants have performed. And as we know, surgical performance improves with experience. The dotted line demonstrates the mean learning curve for the group without virtual reality training. So with traditional training, and the bold line is the mean learning curve for the group with virtual reality simulation training. The performance score improves by 40%. So we bypass the steeper part of the learning curve, moving it from a clinical setting on the patients to a simulated setting. So there is strong evidence supporting the use of virtual reality simulators, and the trainees become less dangerous for the patients. Looking at how we should use virtual reality simulation or simulation in general, it's very important to state that the content of the applied training programs matter. Microsurgical motor learning is highly specific. Several studies have shown no transfer of skills from abstract to procedural skills. So abstract modules is developed to train basic microsurgical skills. So that could be, for example, moving dots around in the anterior chamber. And now we know that it doesn't affect your procedural skills afterwards. So it doesn't have any value. Also, we have shown no transfer of skills between procedures. We've done a study specifically investigating the transfer from cataract surgery to vitreoretinal surgery, showing no evidence of transfer between these subspecialties. This is to demonstrate the specific program that we have developed, investigated, and implemented in Copenhagen, Denmark, which is published in ACTA and available for everyone who should be interested. Of Other educational strategies with a huge effect on learning outcomes. I would mention timing of training should be close to clinical practice, and that is due to the retention of skills. We don't have any specific knowledge on this area in ophthalmology, but from other areas, we know that the retention is probably a couple of months and probably less in microsurgery. The training should be distributed over time, and that is opposed to mass training, which we usually do. So instead of having a course where you train for 7 hours, 2 days in a row, it is a lot more effectful to train these 14 hours distributed over several weeks. The training should be proficiency-based. That means that you should train until a predefined level of proficiency. And that is opposed to the time-based training that we mostly do, where we say that you should train 4 hours on this model. Now we know that the training should be proficiency-based because we all have different learning curves. And also training in pairs has shown a significant effect on learning outcomes instead of training alone. The next important question to be asked is who should train? Looking at the same graph of learning curves, you can see that they start overlapping at approximately 100 surgeries. So this specific training program is only for the new surgeons. We have looked at more advanced modules on the IC simulator, such as the iris expansion ring and anterior vitrectomy, but at the moment, there's no evidence supporting a training program for the more advanced surgeon. Looking at the graph again, you can see that the learning curve continues. So from this, it's evident that simulation-based training is an add-on to real-life surgical training. And this is due to the ceiling effect on the simulator, meaning that you can improve more to a specific point, and possibly also a limitation in our metrics. So in conclusion, virtual reality simulator training significantly improves patient safety, making the trainees less dangerous for their patients. And this is only true by using a structured training program, which should be content specific. It should be proficiency-based training. And for now, it's for surgeons who have performed less than 100 phagos. And it is an add-on to a traditional training program. So our suggestion regarding a surgical training program in cataract surgery, supported by a high level of evidence, is to include virtual reality training after traditional training, which normally would be theoretical education and wet lab training. In the capital region of Denmark, we have implemented the before mentioned training program as a mandatory requirement before attempting live surgery, which of course still should be supervised. Thank you for your attention.
Thank you very much, Anne-Sophia, for explaining us how the virtual simulation programs can help us learn the surgery. We'll have the chance to discuss your presentation at the end of this webinar.